Well, hello, everyone, and welcome to our case conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I'm a CL and addiction psychiatrist at Mayo Clinic, and I'll be moderating this event and introducing our speakers. As a reminder, this event is one of many in a monthly series of alternating case conferences and educational webinars, so be on the lookout for some of these upcoming events that we have. But today's 30 to 45-minute case conference, representing the Med Psych SIG of ACLP, will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end with a Q&A session. So if you have questions, please put them in the Q&A option. Feel free to use the chat for comments, but we only answer questions specifically in the Q&A option. And our trainee presenter today is Dr. William Graft. He's a PGY3 combined internal medicine and psychiatry resident at the Medical College of Wisconsin. And our faculty discussant is Dr. Tom Heinrich, who is a professor of psychiatry and family medicine at the Medical College of Wisconsin as well. And so, without further ado, I'll hand it over to Dr. Graft for his presentation.
Thank you, Dr. Fipps. Today, I'll present a case that demonstrates the diagnostic and management challenges when somatic symptom disorder occurs alongside medical comorbidities and how integrated care can improve outcomes. I was called to see a patient in the emergency department for evaluation and treatment of anxiety. The chief concern was, quote, "I feel hungry for air." This 37-year-old male patient had a psychiatric history of anxiety and ADHD, and medical history of atrioventricular nodal reentry tachycardia, status post-ablation, and sarcoidosis. He presented with sudden onset dyspnea and chest pain associated with significant anxiety. He had experienced multiple similar episodes over the past 6 weeks, resulting in 5 emergency department visits. His anxiety had escalated significantly from baseline, and he had started using clonazepam nearly daily when his previous use was only about weekly. His psychiatric history includes ADHD, which was diagnosed in high school and treated with behavioral interventions alone. Unspecified anxiety disorder was diagnosed in early adulthood and treated with a combination of cognitive behavior therapy and psychopharmacology. Previous medications included sertraline, which was effective but caused anorgasmia, bupropion, which worsened his anxiety, hydroxyzine, which was ineffective, and alprazolam and clonazepam. Both were effective, though clonazepam caused notable fatigue. At presentation, he was taking buspirone 5 milligrams twice daily and clonazepam 0.5 milligrams daily as needed. He works as an accountant and is married with no children. He consumes about 2 standard drinks of alcohol monthly and has a 4-pack-year history of cigarette smoke, but quit 15 years prior to presentation. He denied other substance use. The patient has a complex medical history, which, for the purpose of this case, is best understood chronologically. His first ED visit was 12 years prior to current presentation for chest pain and dyspnea. EKG showed an incomplete right bundle branch block, but the remainder of the workup was reassuring. The ED documentation noted that the patient appeared, quote, very worried and preoccupied with the medical problems. Over the next several years, he had multiple ED visits for chest pain, chest tightness, dyspnea, and palpitations. 5 years prior to current presentation, a transthoracic echocardiogram showed no abnormalities. Results from a 30-day Holter monitor were concerning for atrioventricular nodal reentry tachycardia, which was confirmed during an electrophysiology procedure. As an aside, AVNRT is typically seen in younger adults and presents suddenly with regular rhythm and rates of about 140 to 280 beats per minute. After confirmation of AVNRT, he underwent successful radiofrequency ablation. Since then, he has not had recurrence of AVNRT. 6 weeks following the ablation, he presented to the ED with chest pain, was admitted for observation, and discharged after reassuring workup. Sertraline was started and titrated to a dose of 100 milligrams with notable improvement in his anxiety. He had no ED visits over the next 3 years. When he later experienced palpitations, a repeat Holter monitor was negative for arrhythmias. A screening CT for coronary artery calcium scoring revealed mediastinal lymphadenopathy, which led to a pulmonology referral. 18 months prior to presentation, patient underwent bronchoscopy with biopsy of the mediastinal lymph node. He was discharged in stable condition, but presented hours later with dyspnea and chest pain. Imaging revealed iatrogenic pneumomediastinum and small bilateral pneumothoraces. A chest tube was placed, and he was admitted to the medical intensive care unit for 1 day. After a 3-day hospitalization, he was discharged in stable condition. Pathology results revealed granulomatous inflammation consistent with sarcoidosis. Pulmonary function tests were reassuring, and pulmonology recommended ongoing asthma treatment and yearly CT surveillance. The mediastinal lymphadenopathy remained unchanged on repeat imaging, but episodes of chest pain and dyspnea began escalating in frequency. The patient presented to the emergency department with stable vitals, which remained stable throughout the ED visit. He received 2 milligrams of IV haloperidol for reasons unknown. A focused medical workup, which I will discuss on a later slide, was performed and was reassuring. Mental status exam was notable for an anxious but otherwise euthymic affect with full range. Thought process was mildly circumferential, but otherwise logical and goal-directed. There was no disorganized speech or behavior, and the patient did not appear internally preoccupied. Regarding his medical workup prior to psychiatric consultation, initial EKG showed normal sinus rhythm, first-degree AV block, and incomplete right bundle branch block, which was consistent with prior EKGs. Basic metabolic panel was notable only for a bicarbonate of 21. CBC and serial high-sensitivity troponins were within normal limits. A repeat EKG showed sinus bradycardia with persistence of the first-degree AV block and incomplete right bundle branch block. No imaging was obtained. Our differential diagnosis included somatic symptom disorder, panic attack, illness anxiety disorder, exacerbation of sarcoidosis, and recurrence of AV-NRT. This brings us to our key discussion question. How do we diagnose and manage somatic symptom disorder in patients who have comorbid medical conditions requiring ongoing monitoring and further workup? And at this point, I will hand it off to Dr. Heinrich for a discussion of this case.
Thanks, Dr. Graff, for that great, interesting case presentation that really does demonstrate the complexity that we are often confronted by as consultation psychiatrists. And I'm gonna have to stop sharing because it's... All right, so we're gonna focus on a couple of the conditions that the patient does have, such as sarcoidosis and AV-NRT, and talk about a couple of the psychiatric diagnoses as well. I do want to recognize that earlier this year we had a great webinar on somatic symptom disorder, so I will touch on that, but I'm going to spend some time stepping back and putting my administrator hat on and really thinking about systemic and programmatic ways that we can address this complexity on an outpatient kind of platform. So if we talk a little bit about sarcoid, what we know is that it is a multi-system inflammatory disease that can involve everything from the ocular to neurology to pulmonary and cardiac. If we focus on our patient who's presenting with both pulmonary and cardiac symptoms, what does that look like? Well, from a pulmonary standpoint, that's by far the most common symptom presentation with over 90% of patients with sarcoid presenting with pulmonary or having pulmonary symptoms. Most commonly, this is a dry cough, chest discomfort, or in the case of our patient, dyspnea. Unfortunately, a significant minority of these patients go on to develop pulmonary fibrosis and potentially even pulmonary hypertension, which is a significant contributor to the mortality of patients with sarcoid. Some patients, thankfully a very small minority of patients, will develop cardiac sarcoid. About 5% of patients with sarcoid will have cardiac manifestations of their sarcoid disease. Usually this is a ventricular arrhythmia or congestive heart failure, sometimes a higher order AV block. It really depends on where those granulomas form in the cardiac tissue that's responsible for it. Though really rare, cardiac sarcoid is responsible. It's one of the leading causes of death in patients with sarcoid disease. So that's one of the reasons that Dr. Graff included that in his differential diagnosis. The good news is we have an CT, recurrent CT of the chest, that really shows that this condition is stable. The other disorder that the patient does have that could present with the cardiac and dyspnea is his AVNRT, his atrioventricular nodal reentry tachycardia. And what this is usually a reentrant tachycardia, so it's a ventricular tachyarrhythmia, or it's an atrial tachyarrhythmia, that atrioventricular nodal reentry tachycardia, that's responsible because there's both a slow and a fast pathway, one going anterograde, one going retrograde, that results in both the atrium and the ventricle actually contracting at the same time, which isn't really great. The good news is it's usually fairly well tolerated, with most patients having symptoms, and it's usually not life-threatening, but it is one of the most common causes. And when you look at an EKG, it's usually a narrow QRS tachyarrhythmia that we end up seeing. You can kind of see, based on the presentation, it's what our patient's experiencing, the palpitations and the dyspnea. What's really interesting is this neck pounding sensation. If you ask a patient, kind of going through the view of systems, and you ask a patient with this AVNRT, they'll often present with this or complain of this neck pounding. And the reason for that is, as the right atrium contracts, the tricuspid valve is still closed. So you're getting this kind of jugular venous elevated pressure, and that causes a really fascinating physical exam finding called the frog sign. And you can see why it's called the frog sign. Really kind of great thing to actually see. Now, this isn't our patient, but kind of interesting to kind of take and amaze the medical students at the bedside if you're confronted with this. So coming back to the somatic symptom disorder. So the really important thing to know about somatic symptom disorder is the diagnosis is not based on the absence of a medical explanation for their physical signs. It's not based on medically unexplained physical symptoms. It's based on the positive symptoms that the patients are having. And those positive symptoms are these abnormal thoughts, feelings, and behaviors that the patient is having as a response to these somatic complaints. So the distinctive characteristic is not the somatic complaints per se, it's how the patient responds and understands and interprets those symptoms. That's the pathological aspect that we're looking for here to make the diagnosis of somatic symptom. So what goes into the symptom, somatic symptom disorder? What causes it? And we're going to take this as our patient. There's psychiatric comorbidity. Our patient has a history of an undifferentiated anxiety disorder and a history, more distance, of ADH. It's early life adversity, which we didn't come up with anything when Dr. Graft and I thought about this patient. It's maladaptive coping styles and cognitive styles. This patient really has a catastrophizing way to approach things and ends up going to the emergency room an awful lot. We couldn't think of any family or social context. That seems to be going fairly well for the patient. But he does have some medical conditions, which we just spent some time talking about, that may be contributing to this. The unknown of a recurrent sarcoid or a relapse of the sarcoid, or breaking through the ablation that he had for his arrhythmia. And then there's the health system interactions. This guy had a pretty significant interaction with the health system. He had an iatrogenic pneumomediastinum that resulted in him going to the ICU. That's pretty significant, and I can only imagine the trauma that that brings up with the patient. So if we think about somatic symptom disorder in our patient, how do we approach that as the primary care provider? Dr. Graff seeing the patient in his primary care clinic. We think about it with regular follow-up appointments. We want the ability to see the patient with his current symptoms. We don't want him or her to have to develop new symptoms as kind of the ticket of admission to another primary care appointment that we now have to investigate. We want to examine physically the areas of concern, looking for objective evidence of disease or progression or something that would trigger a medical workup, not relying merely on on the subjective complaints. And the goal is to avoid unnecessary tests, labs, referrals, or emergency room visits leading to hospitalizations. We want to offer reassurance and reattribution. We don't want to provide insulting normalization of symptoms. Everything's normal, everything's fine, get on with your life as we interact with these patients. And for some patients, we really need to limit stable symptom presentations and calls between visits, really relying on those regular follow-up visits. And I hope you're beginning to see why I think primary care settings are often optimal for managing these somatic type of patients. Primary care patients, as a primary care provider, we're really good at addressing individual disorders. This patient just had sarcoid, not a big deal. Just had IBS, not a big deal. Or coming complaining of hip pain. And we're getting better in primary care about managing comorbidity. In this case, the patient had all of them, and how do we go about managing that? It gets a little bit more complex for primary care providers when you add behavioral health conditions kind of across all these, and that's very clearly the case in our patient. And again, as CL psychiatrists, we live complexity, right? We live in this area of comorbidity with medical conditions exacerbating psychiatric conditions and psychiatric conditions exacerbating or leading to medical conditions. So comorbidity is really important to us and really addressing that complexity. Well, how common is this comorbidity in the patients we're seeing? This is a population-based cohort study out of Denmark looking at almost 600 individuals. And it really does demonstrate the significance of comorbidity in patients with mental health issues, psychiatric illness, with almost over 35% of patients having some sort of circulatory disorder and almost 35% having a pulmonary system issue, similar again to the patients that Dr. Graf spoke about earlier. But one of the take-home points in this study out of Denmark was the life years lost due to psychiatric comorbidity of just over 11. Again, different healthcare system, but pretty significant life years lost as a consequence of this comorbidity. So how do we address it? I think many people are on the call are very familiar on how we do this on an inpatient side. Ideally, we have behavioral health, a trauma-informed approach to care from everybody from our phlebotomists to our nurses, to our janitors, to our providers. Then we have the good old-fashioned, what I trained in, the reactive consult model. Somebody calls me, I go see the patient and deal with it. And then we have the much more enlightened, cost-effective, kind of proactive model out there that's using objective measures to identify who may or may not benefit from a psychiatric consult. And then for the most acute, there is the med psych unit model. Here at the Medical College of Wisconsin, we call our med psych unit a medical unit designed and staffed to care for these medically complex, behaviorally complex patients, the complexity intervention unit. And if we take this model tiered approach to the outpatient, we have a good way to think about this. We have primary care providers that have interest or extra knowledge in dealing with behavioral health. In family medicine, there's going to be a behavioral health extra year, a fourth year added on. They're testing that within family medicine right now, given the comorbidity. There's the old model of referring to psychiatry. There's the collaborative care, really the gold standard for addressing depression and anxiety within primary care. And then there's the model that Dr. Graf saw this patient in follow-up, the med psych model, a model similar to the med psych unit. You have a dual boarded provider providing the care for these patients. Almost done here. Very similar to the med psych model of clinics. It's very new and there's not a lot of data to address the effectiveness. There's a lot of gestalt that it should work. There's a lot of logic, but not a lot of evidence. And the same for the med psych clinic. We have this one study that I was able to identify looking very small cohort of patients, about 120, 60 that were seen within a med psych clinic and 60 that were seen within a general primary care clinic. These patients had med psych comorbidity, and they were able to show a statistically significant improvement in satisfaction of the patients that were seen in the med psych clinic. But that's not all where it's patients feeling satisfied or good, but we want outcomes to demonstrate value. And the study did demonstrate a non-significant trend towards fewer emergency room visits and fewer hospital admissions, but really no difference in another important metric of quality of life. So we have a ways to go in studying this kind of model of care, that most acute model of care. I would like to point out, just to educate about these kind of dual training models like Dr. Graf's and the good news, I mean, the good news is it's a growing field, but we have a way to grow. We only graduate 25 Dr. Grafts a year, internal medicine psychiatrists. Um, I'm family medicine psychiatry. That's even less at 14 a year. The triple board, the real go-getters are those child psychiatrists, the adult psychiatrists, and the pediatricians. There are 29 of those graduating a year, and 5 neuropsych individuals. Very competitive. In last year, over 90% filled an IM Psych, and the rest were 100%. CL psychiatry, there's a lot more of us CL psychiatrists out there with 113 positions and just over 70 filled this academic year. So it's more of a collaborative effort than either or, and I think that's important to drill home. And that's all I got, and I'm going to turn it over to Dr. Graft here as soon as I can stop sharing.
Thank you, Dr. Heinrich, for the excellent discussion. Here's how the case was managed. The patient was informed of his somatic symptom disorder diagnosis and was told that treatment for somatic symptom disorder and ongoing medical workup would not be mutually exclusive. He agreed to establish with our MedPsych clinic for primary care and was seen every 4 to 8 weeks over the next several months. Cardiac MRI, performed 1 month after I met him in the emergency department, did not reveal cardiac involvement of sarcoidosis. Buspirone was stopped and sertraline was titrated to an effective dose of 75 milligrams. In the 9 months following our initial emergency department consultation, the patient has had only 1 emergency department visit, which was for influenza A. His clonazepam was last refilled for a 30-day supply 4 days after I initially met the patient in the emergency department. And at this point, I'll hand it off to Dr. Fipps for the Q&A portion of the session.
Excellent. Thank you both very much. An excellent case presentation as well as a really good discussion. And to our audience members, if you have questions that you'd like answered in this section, use the Q&A option of Zoom and not the chat. A few questions have already come up a bit here that I want to discuss, especially regarding the excess mortality that you mentioned associated with mental illness. That was a pretty powerful slide that you showed there. Do we know what some of the predominant causes that link that increased mortality that was observed with mental illness in that slide?
Yeah, that's a great question, Dr. Phipps, or whoever asked it. I think so. The natural causes account for a majority of the excess mortality that's associated. Probably about 2/3 or over 2/3 of those excess deaths are associated to natural causes, with the remaining almost 1/3 due to suicide or homicide. And of the natural causes of death, it's usually led by cardiovascular disease, neoplasm, or kind of pulmonary conditions. Again, our patient having 2 of those, cardio and pulmonary. So, yeah, and I think that's a really important point in that most of those cardiovascular or other natural, quote unquote, natural causes are preventable with good care, So I think it's really important that we pay attention to that.
Gotcha. It's a good point. It's a very good point there. And from the flip side of that, then, does this vary if depending on the mental illness that is being considered as the comorbidity as well?
Yeah, there's that link, right? And it does vary. Certain conditions such as schizophrenia and substance abuse have much greater life years lost than, not much greater, but they have more life years lost than anxiety and mood disorders. And the more severe the mental illness, the more comorbidity that's occurred within behavioral health diagnosis, the greater the life years lost. So schizophrenia and substance abuse are kind of up there at the higher end. Personality disorders is also kind of up there, which I found fairly surprising. And then you have the anxiety and the depression towards the bottom there.
Excellent. Thank you. Thank you. We've got a few questions about methods of collaborating with primary care versus palliative care as well. And there's one question here that says, I wonder if you have any insight into the role of palliative care, especially with psychiatry-trained palliative care physicians in some of these cases.
Yeah, I think that is a wonderful area of collaboration. Both the patients benefit from, but also the treatment team, the palliative team will also benefit from that degree of collaboration. Yeah, there are ways of looking this both on the inpatient side, having somebody actually round with the palliative medicine team. here at the medical college, we have a health psychologist that's the primary behavioral health rounder with palliative medicine. And then we have it also in the ambulatory setting within the palliative clinic, co-located. So yeah, this is a wonderful area of collaboration without a doubt.
Excellent. And from that same viewpoint, when we have a patient with somatic symptom disorder, is there an optimal frequency to recommend they follow with the primary care? And how do we navigate the discussions with the patient, but also with the primary care team, saying how do we help them engage in empathic validation without this insulting over normalization that you mentioned, without enabling? How would you approach those conversations?
Yeah, I mean, unfortunately for it's often a challenging conversation for the CL psychiatrist to have with a primary care provider because you're going to be telling them something they often don't want to hear. Like, you're going to have to see this I mean, ideally, you're going to see this patient more often. And I usually start with every 4 weeks is my initial recommendation. I mean, it depends on the severity, of course, it can vary, but for the ones that are bad enough for them to ask to see psychiatry, we usually recommend about 4 weeks as a start with a goal to taper. You really need to educate the primary care provider that it's really an investment of their time for better long-term outcomes. It's a lot of work up front, but in a year or so, as you work towards that reattribution of symptoms or that identification of symptoms, as you use that every 4 week visit to build that relationship and that reattribution skill set, you can start tapering those visits and the patient's symptoms improve and your life gets easier as a primary care provider and the patient's doing better. So there's a lot of upfront education as you deliver that bad news, right? Same as with a patient. You're just doing it with the primary care provider.
Absolutely. That's the L of our CL, right? Being
Yeah,
able to
yeah,
liaison with
exactly.
people. We've had quite a few questions about medications in here. One, and we can kind of combine some of these at least. So, are there medications that we may attempt to maybe avoid or use less frequently, or even advise our colleagues about in that may worsen symptoms and or outcomes for patients with somatic symptom disorder? With another one kind of around the fact this patient was on clonazepam and began using it more frequently. How would we address those considerations?
Well, before we actually talk about which medications to avoid, I mean, I think we want to focus on the medications that are actually effective in kind of treating these conditions, because that actually leads to less inappropriate medication prescribing, right? Um, and that really comes down to like first and foremost comorbidity. In this case, we're dealing with a patient that had an anxiety disorder that sounded a lot like a panic disorder to me, maybe some generalized anxiety disorders. So I think the SSRI as well as the buspirone that were initiated, I thought made a lot of sense. And ideally, again, to the point of avoiding medications, the utilization of those medications hopefully will eliminate the need for a rescue medication such as the clonazepam, which may have led to eventual misuse. So I tend to avoid benzodiazepines in patients that may have an anxiety disorder with or a somatic symptom disorder with a very predominant anxiety component. It's not going to help their somatic complaints. Everything we just talked about is what's going to address their somatic complaints. The benzodiazepine is just going to temp down the anxiety associated with those somatic complaints for a brief period of time. And that's exactly what we observed in this patient. So.
Excellent, excellent. I think that's really good feedback for that case, especially. But also, I'm sure everyone has probably a case in mind where that could be very applicable as well. Another good question, kind of backing off of that one a little bit, was how do we measure success in patients being treated for somatic symptom disorder, and how do we help approaching a patient who may be resistant to approaching this from a primary PCP level rather than having multiple specialists?
Yeah, so another wonderful question. I mean, I think that I think looking at primary, I mean, if I look for objective evidence, I look for utilization metrics, how well we're doing from a utilization standpoint. I think that that's really important. It can be everything from the amazingly expensive utilization, such as emergency room visits or medical admissions or tests, but it can be primary care utilization or urgent care as well. Um, I also think it's important though, and I push for this within our primary care when we look to measure outcomes within collaborative care is quality of life, the patient's quality of life. One of the things you see consistently in patients with somatic symptom as well as other behavioral health conditions in primary care is a decreased quality of life. And that's some of the best things we can do for a patient as CL psychiatrists and as primary care providers is improve quality of life. We often lose sight of that. And I think that that's an important metric to follow. Somebody's quality of life is going to be improved if they're not overly focused on somatic symptoms.
Yes, great way of ending the webinar, to be frankly honest with you. A very poignant point there that certainly is something to reflect on. So I appreciate everyone's involvement in the webinar. I apologize we weren't able to get to every question that was in the Q&A. If you missed any part of the case or had questions about references or anything like that, this video will be posted on the ACLP website under their YouTube channel as well as some of the social media sites like Twitter, now X, and Facebook. I want to personally thank the panelists for an excellent case discussion and an excellent case presentation and a great Q&A session. Thank you, audience, for being very well involved, and we'll see you next time at the next webinar.